Can you still hear me?
Yep, I can.
Amazing. So for those in the room, if you want to turn around, panelists this way, they know that this to work. So I'm really grateful that I've got three wonderful oncologists, as well as the four oncologists who decided to disappear on me. That's weird. Yes, you need to come and sit here by the both of them. So I'm going to ask for the four oncologists that I have here. So we've got Dr. Binyamin, I can't pronounce that. Sorry about that, from Mark Irving, and then we've got Dr. Shahabi, Dr. Slee, and Dr. William. I'm going to ask them all to give me 2-minute synopsis of one thing that they're experiencing with therapy with Mr. Optune or having patients from Optune, and then I will open up the discussion with others so that it's a question. So I'll go with Dr. William, as he will need to disappear, and Dr. Shahabi is kind of silent.
So apologies, I forgot to chair the meeting by Shahabi. So getting access to Optune is difficult, and although we've made significant progress with 2 insurers, it is worth remembering that the first time we've got to approve access to Optune is because the patient's wife worked for a very large multinational, got the head of HR at the company to talk to the medical director of Bupa, say if they didn't approve the Pakzad treatment, then very large multinational would remove their entire insurance account. The reason I say that, strategy, since Kathy's talk this afternoon, is we obviously need to work collaboratively with everyone to introduce Optune, but there are some times when we need to be prepared to push. And we've only got where we are because we've pushed. I've never had an insurance company write to me or ask if I'd like to prescribe what we should do. And so we're only where we are because we've pushed and we will have
I think I agree with myself here. I think access would be very different and this can take a too much to filter. Insurance company argue that a patient had breathed through astrocycle might not achieve into the relatively recent distinction that WHO now makes. And there's lots of back and forth to go over many of them to their places in category. So this access would be a big problem. So my experience with Optune, I mean, unfortunately, as we know in the NHS, it's not approved, and we're not part of it. And I don't know, we're not part of the FOB or the trials per se. So my experience is purely for patients who actually got that insurance. And as both Matt and the past mentioned, access has always been. Then I always have look at another perspective as well. When I see patients in NHS, do I talk to them about Optune, which would be actually an interesting discussion. I would want to have with obviously patients sitting here as well, because ethically, where do we stand with that? Can I actually not mention a device which has got a phase 3 randomized controlled trial evidence, which is what the NICE is actually suggesting that we should be offering patients this. But is it ethically right to discuss that? And shouldn't it be the patient making that decision finally? So I would love to discuss that later on.
Brilliant. That's just like senior comment, and still people in the audience hear us clearly. Or would you like us to speak up a bit louder?
It's a little bit faint.
Okay, is this better now?
Yes. Yeah.
Brilliant. So everyone needs to speak the voice, please. Dr. Matt,
So just following on now from Mike's point about the ethics of discussing this with patients in clinic. Recently received circular from leading oncologists that not bringing up Optune as a treatment could actually be a problem in the future because it could consider providing a patient Optune. And the decision ultimately has to be made by myself and sitting across from me. And I echo all of the issues that we've had in terms of self-funding, private medical insurance acquiring Optune, and all of those issues are unfortunately amplified for lung and mesothelioma because it's that far behind on the curve for now. Hopefully, we'll catch up with that.
So I'm going to go back to the people if you have any questions, otherwise I've got a series of questions that I can answer. So I'm going to ask in the room first, if anyone has questions, I'm going to invite people ask specific, is that oncologist or in general? Speaker voice. Speaker voice, please.
Speaker voice. Can you hear me over there? Okay, great. So my name is Kathy Oliver. I'm from the International Brain Tumor Alliance, which is based in the UK, but it's a patient organization for the world, basically. And it's very interesting that the comments on whether healthcare professionals should mention the availability of option. A couple of years ago at the British Neuro-Oncology Society conference, which is the professional conference that all the neurologists and some neurosurgeons go to, we had a big debate about this because the feeling is generally, no, the doctors should not tell patients that there is a choice out there if they can organize insurance payments themselves. And I think the patient advocacy perspective is one that says, if a doctor does not tell a patient about this treatment as a potential route, the patient then would not be able to make an informed consent. And informed consent, as you all know, is a vital part of your treatment. You have to know, you have to decide what the best thing is for you, having had medical advice. But the medical advice really does need to include all of the possibilities. And we do get a lot of people contacting us saying, we never knew about that therapy or this therapy or whatever. And it's not just option, it's other therapies as well. So I just wanted to mention that because there is a very strong feeling, at least in the academic community, about full disclosure.
Yeah, can I ask? So I certainly agree with that, and I do practice that. But when you're looking at the NICE guidelines, which is actually there, but it's 1.2.26. That's the thing. Which unfortunately, going in my mind, saying that you should not be offering human treatment for your patients. But I agree with the patient advocacy will say that. Look, I always say this to my patients, but if my treatments will cure a patient, then I don't need to actually talk about anything else. But we all know that it doesn't. And in those situations, it is actually forms part of my role to explore and just talk to the patients about what is available out there beyond what I can offer in NHS or even with other insurers.
I think, do you agree that? Sorry, so I've never in my career been in a situation where I'm having to decide whether or not to discuss a treatment with a patient that is published on an international guideline, but not on my own. Does that make sense? Yeah. So it's available to North America. It's not available to us. Someone could just Google it and say, rightly so, why can geography dictate something as important as this? So it's specific. So chemotherapy, immunotherapy, TCAR, radiotherapy, it's all standardized in the West. But Optune is a unique student.
It's because we're not economically viable. That's why you won't invest in it in the UK. The choice that you make, sorry to put it, but I just feel very strongly about this. The choice to not tell patients is denying them a choice, and therefore they just exist. But they don't exist because it's terrible. And my experience with my oncologist and everyone in the NHS is, you've got this disease, therefore you are going to be here. I better tell you prognosis, and I don't want to know my prognosis. I better tell you need to. No, I don't need to know, and I'm going to be here in 4 years' time. I'm going to be sorry to not bang out by ironics. To not be told there's any hope is criminal, in my mind. And I mean that criminally. You've got no right to tell me I've got no hope. You've got no. I'm sorry, I'm putting it yourself because you mentioned it. It's an ethical thing. but don't hide behind the efficacy of it. In other parts of the world, it's ethical. You can't say it's ethical not to tell me something because I can just Google it. If you have been in the space where you've got pure panic of knowing that you're going to have an operation in 24 hours, not 2 weeks, where you can try it on you, then are you going to Google it? No, you're the NHS, you're the specialist, you're the people we trust. My mum's a GP, you trust. The consequence of your efficacy is that I lose trust in you and the organisation.
I think 100% agree with what you're saying, and it should be a joint decision. And the role of the clinicians or consultant is to, make patients aware of what is out there, and the decision should be made together. So I will just point out what was there in that, nice guidelines, which we're all supposed to adhere.
I'm sorry, I got excited about that.
We'll talk about this a little later on too, because this is my presentation is whole political and policy issue. But with regard to the guidelines, which are called NG 99, but from NICE, the National Institute for Health and Care Excellence, it does say do not recommend or use Optune. However, the guidelines were published in 2018, and they haven't taken account of all the evidence that came from the EF14 trial. So I think you can safely say, and this is something we are challenging as patient advocates, you can say that the guidelines are out of date, things have moved on, and they need to be changed. It's pretty clear.
Yeah, today an MP is launching a 10-minute bill to try to get doctors to tell people, and that's the biggest problem I suspect, but then offer what you get in Cologne, what you get in CGAP for patients in the UK who can't travel to Germany. I'm lucky enough to be able to afford and travel, but the standard of care it's a joke. It needs to change. Otherwise, you're basically giving us a death sentence.
I think the viewpoint when I'm through.
Yeah. So the view I take, and I'm sure my colleagues with the same view, is that NICE or any of the guidelines are guidelines. I don't think we have to adhere to them at all times. We can be very honest with the people, patients, and say, this is one of standard of care, but ABCD is out there. Do you want to access it? I've had patients who have discussed options and turned it down, they don't want it. It doesn't fit their lifestyle. That's happened. That's a choice. I've had 5 patients turn it down because it doesn't fit with what they envisage life to be. That's a choice. So I think that's the view I take. I'm sure we should put it on the table. But where I think the ethics of it comes in is, I've had somebody who said, I want to sell my house for money. That's not my decision. But then I am duty bound to say, look, you have to put it evidence. If it was curing you, I would say yes, sell it. But then if you're throwing at me and saying, should I sell my house for money? How do you answer that question?
Yeah, I totally agree with regards to that, but it's like any trial, are you relevant? Have you got Bupa? Have you got whatever the other insurance company is? Then you would consider this. But no one ever asks that question in the doctor oncology, obviously not the surgeon side, but you never get a chat. Not from Macmillan nurses, not from anyone.
I agree with you. I think if you put it on the table, at Chatham Court, because some of the people whose insurance strongly turn it down, they're paying for it out of their own pocket.
Yes.
And they are on the NHS with us, but they're having a treatment on the NHS and they're paying for it. Okay? So what I'm saying is we do discuss, but where I think, just taking this one down, really, I think that is when they're selling the house kind of a thing comes before.
Yeah.
I honestly don't know how to answer that question. That is really, I think that the facts will say, but I must make a decision.
And I think how this whole thing has affected my clinical practice, I'm now making a point at some point in the consultation to specifically ask the people, have you got private medical insurance? Which is something I never thought of asking, 2 years ago. Oops. it's an unfortunate change in the way we're practicing medicine. But I think it's a necessary one given the context.
How about a little bit more radical? How about you just say privatise part of the NHS? Go for it, guys. Get private medical insurance. What the hell?
It's not just for option where it's not in the UK guidelines. I do prostate cancer and like stereotactic radiotherapy of prostate is still not on the NICE guidelines. It's recognized, UK did probably the biggest randomized trial in the world, still not on the UK guidelines. And I very routinely say it in a rather rude way to all my patients. Are you privately insured? Or do you have a lot of money to throw at it? Because for £35,000, you can have this. And I'm very honest with that. And they say, no, fine, that's it. I've mentioned that for you about it. I leave it at that.
That's really important. I think I have seen it as being in non-oncology clinical practitioner working in here that we are quite fortunate that we are quite proactive in offering options and discussing it with our patients. But I think one question that I will ask is how do your other colleagues respond? And why do you think some of your colleagues don't prefer patients to Optune? Because I think that leads into your question about there is not standardized offering. So I've only ever seen it at Imperial where we offer it routinely every that's where practice. But I will go to you. What's been happening?
Yeah, I think it's first place. When I start clinical practice, to be quite open, I was actually quite, what can I say, maybe I was looking at it quite critically. And maybe I think all clinicians should look at all the trials coming out critically before you can actually be certain that what I'm offering is, is something that is worth it. Obviously, it's one of the things that we always say initially was the fact that it was a single trial showing that benefit. But at the same time, when we've got mounted evidence for us, it becomes important that we should offer that to patients as an option, even if it is outside. A lot of the time, what I've seen is that some of the colleagues who are not experienced in, in the treatment is where they haven't seen a lot of patients going through the treatment, is where they take a step back and think about, okay, it's not available just it is something that I can offer or not, and they don't. But so it's probably also part of the whole neuro-oncology community, and also not probably to make this in a way educate the clinicians as well of the benefits of this throughout. I think that's probably that falls on all of us who have got experience as well, and probably the company as well should be looking at doing that.
I think I agree. It is a lot. I think the community was skeptical. When it first came, like, how do you expect 200 currently to do the job that radiation or chemo or surgery hasn't done? I think that's how it started. Second thing was access. It was so expensive, we just couldn't access it. I think we were lucky enough way back perhaps 2016 and 17 when that compassionate program started. And we're lucky at Sheffield was really one of the few places in the country that were able to get hold of a handful of devices and actually just give it to our patient. I think, and we saw some very good responses that we would not have seen otherwise. So for us, that was a big turning point, saying, okay, there is something here. And I think the third thing attached to that was the fact that it's relatively very clean, side effect-free device. For much less benefit, you would give people the price of low steel and all that. So, and I think I agree with you. In the end, it's more about communication, education, not just for the patient community, but also for the healthcare providers.
Sure, what's the expenditure? Going to bring the 17 to assistance.
That's an ongoing response, isn't it?
Congratulations.
Yeah, I'm thinking.
It just comes back to the same question that, we're asking, what is the effect of it long term? Is with that single treatment and so on.
I think the only thing I would add, I think there is a lot of biology that we still don't know and understand. Just that you might have, I was saying, we have a patient who's got a basically who's had a bet going that he in 20 years will come and have coffee with me. He's not had option. He's had standard radiotherapy, chemotherapy. He's now in 60th. I don't know why. Great, brilliant, he is recurrent, but I don't know why. He's not had anything other than standard radiotherapy, chemotherapy, and he's absolutely fine.
But it's increasing that percentage population who goes into the better side of the statistics is whatever we can use to try and help them to be on the better side of that. So we go back, surgery is the most important thing that we've always had to remember. But biopsy was the surgery to get them to the better side. Adding chemotherapy along with radiotherapy has improved that. We know that TTF is adding to that. Maybe other treatments will come with it and with that. And if we can let facilitate people, as the previously Matt showed, 4-year survivors being 27% or more, potentially being less than that. And we need to look at each and every benefit that we can get from whatever treatment is out there.
The biological rationale is actually one of the most important questions. Why I think starting a day like this with all this presentation is probably the most important way to start. Because the resistance that I most often encounter from my lung oncology colleagues is number one, they don't understand how it works. Number two, it's too expensive. Number three, the benefit's too small. So I'll go through them first. So always explain very clearly the biological rationale. Put that to one side. Right? In general, in medicine, you want to have a biological rationale and you want it to be supported by trial evidence. Obviously, if there's no biological rationale and no trial evidence, you don't want to have that treatment. But there is often situations where biological rationale does not exist, but there's trial evidence. Good example, classical example is electroconvulsive therapy for major depression. Nobody knows how it works. We know it works, so we keep doing it. And I think Optune is not at that stage because we've got an evidence-based approach in terms of biological rationale. The other situation I find is that people say it's too expensive or the benefit is not enough. I'll explain the analogy from a particularly aggressive type of small cell cancer. That was the 15% of lung cancers that I talked about. One of the most groundbreaking trials in the last 10 years has been an immunotherapy trial, which costs about £10,000 per cycle. And it adds an overall survival benefit of 2 months. And everyone accepts it, hands down. It's the new standard of care. So why not for Optune? This is just the argument that I have. So the common barriers, which is why does it work? It's too expensive and it doesn't work well enough. I think I've got challenges to all of those. I'm attending a Visit Glioma national talk next Friday, specifically to try and work out where we're at with Optune in that sphere.
So just down to that, what Lillie said, it's also important as clinicians for us to be clear about if there is evidence of it. I'm sure there will be people out there who will be happy with things that just got no evidence, but it's important that when we are actually talking about this, it's important to say what evidence is out there and to have that discussion with the patient. And I have patients bringing in one treatment or the other that they've seen or their families have sent through. It is partly a responsibility of the court to ask to say that is there any evidence? If there is evidence, if there is no evidence, we can't really endorse that. And that's important for us to make that distinction between what is good evidence and what is not good evidence.
Do you understand why it's so expensive? Is there an anticipation of the cost will come down in time as long as we do it?
I suspect a lot of it is R&D. There is a huge amount of money that's going to develop into it, into getting exposure getting the arrays more user-friendly than that. Ongoing support, troubleshooting, monitoring, I suppose, but I suspect the biggest chunk is the company in the day that was established in. Somebody's invested in insurance, and they have to get their contract as well, otherwise none of the development will happen.
One reason I'm excited about the lung cancer development is the fact that because of the number of patients, getting lung cancer is so much more than with brain cancer. Hopefully that volume increase would ultimately bring the costs down. I'm hoping that, I don't know anything, for sure from the company perspective.
Yes, I'm really sorry, I didn't really hear you. Further to the point you made about patients who have just like standard care and survived experience. Well, I travel around the world, and almost everywhere I go, I meet a glioblastoma patient who is way beyond the prognosis that was given to them. And I've met people 10, 15, even 20 years. And when they tell me that, they say, perhaps I have a wrong diagnosis. This is the doctor. I know this is the clinical response sometimes, but no, they haven't. They are genuinely glioblastoma patients. And I think the main thing about that is it's very harmful to us. We shouldn't have false hopes or, crazy hopes, but we do need hope. I mean, I had a son who had a brain tumor, so I've been on the journey as well. And this is a rare disease. It's a rare cancer. It's a neurological disease. And so it's got a lot of complicated aspects to it. But we did ask the clinical context we had, why don't we study the long-term survivors and try and figure out what it is that makes them survival, even on standard care. And there's a study by someone called Professor Michael Weller on 5-year plus glioblastoma survivors. I'm not sure it's been published yet, but I know it's been in the works, and you may find something online about it. And they studied tumor tissue, bloods, all the fluids that you could possibly provide. So it's a mystery, is what I guess I'm going to say. You can throw everything at it, have a shorter survival, or nothing and have a longer survival. It just depends on the individual, I guess. It's very
And I think you take that point forward again, you see, it's got to be in the biology of the individual.
Yes.
Yeah. So I think actually the World College of Surgeons and the latest guideline is that wherever possible, do a debulking operation and not just a biopsy, so you get maximum possible amount of tumor, so you can actually study in greater detail. I suppose you can shed more light on that. Yeah. And in this country now, whole genome sequencing for brain tumors has been rolled out, which means we get far more information, and that should go a long way in developing the understanding of why tumors are different.
We're so used to chemotherapy and radiotherapy, but there are lots of devices out there being developed and new approaches to treating brain tumors. Focused ultrasound is one that I think is quite interesting. It opens the blood-brain barrier to get drugs through faster and quicker. So personally, I think there is hope out there. Finally, there's a lot happening, a lot in pipeline. So
Please hold for one moment just to see if anyone who is remote has a question, because I do appreciate probably want that. So if you are in the audience and you are working or they can. Thanks. Oh, don't worry, I'm multitasking. If you are in the audience and you want to unmute, otherwise I will leave final remarks.
I was going to say on that kind of thing. So when I was doing my training about 2011, this term came out, the hallmarks of cancer. The hallmarks of cancer was revolutionary in its time. It said 8 sort of pathways that led from normal cell cancer to becoming a cancerous cell. And then a few weeks later, once the genome sequencing started to kick in, a new term came up, molecular portraits of cancer. I think we're eventually going to end up in a situation where you will sequence someone's DNA and you will get a molecular microRNA portrait of that, and we'll be able to tell it specifically. So I think that's progressing in one way. But I think there's another black box, and in that black box are all the things that you mentioned. there are all these adjuncts that we're not really fully invested with it. Beyond chemotherapy, immunotherapy, radiotherapy, like the ultrasound, like the Optune, and put it all into this one block. I think that's where most of the, I think with things like chemotherapy, immunotherapy, and radiotherapy, it's always, the wrong thing, probably the wrong thing to say, I'll prove myself wrong in 2 years' time, but we might be on the plateau of that curve, and we just need a new curve, which is why I'm particularly excited
I
about
think what you just need to do is have an attitude to change. Having an attitude to change, small incremental changes will lead you to want to change more. As a patient and other patients in this room, 20 years of no change to standard of care, not freezing or not having a fresh sample, despite Brain's Trust pushing for this for so many years, offering to buy freezers. What is
Final remarks, sir. Thank you.
From what what Lillie's saying and what he said, the field has changed. Along with the TTF, with the whole genome sequencing, there is actually advancements that is happening around the world. More research is happening, about brain tumors now, ultimately. So if you look at the pediatric glioma space, there is actually more drugs that's been approved. If you look at North America, looking at the mutations which is actually there is more drugs that's been approved, which is showing an impact. Not yet seen in the adult glioma, high-grade glioma yet, but I think that's probably because the frequency of those mutations are lesser in adult glioma. But there is change that's happening. There's work going on with the CAR T-cell therapy, which is actually going on. There was a discussion in North American conference even last week, which is talking about specific midline gliomas where CAR T-cell therapies should have some initial benefit, which is exciting to see that. We're not there yet, but I think at least I can see that from when I started my career to now, there is some hope or some work going on, which gives us a bit of hope.
Frustrating this movement, and I see what you're saying. I suppose in NHS context, one potential explanation is a finite amount of money and resources, and bodies like NICE or they have to prioritize what are they being spent it on. And I think that's the one big reason why the pace of change is so slow.
I will add, I'm not sure if this was to comment, because I do know, that is why we strategically have invited Captain later on, so we can have a wonderful discussion about nice politics and the barriers that we are facing. But I think as the author we have shown, as well as this morning, a lot is happening, and we need to still keep pushing through and keep showing why Optune is so important, both as to the patients, to the research, to the caregivers. And I think it just shows by doing this, we can start to hopefully make that change and move forward and not have pause 20 years for Optune. So I'm going to let you all go off for a lunch break. So for those that are in the room, we do have lunch back in the foyer, but I will ask whoever is remote as well to please come back at 2 o'clock, because I'm going to try to go back on schedule. So lunch is shorter, sorry. But then we will be go back to our half-day schedule. Thank you. Thank you. Are you going?
Thank you, everyone.
Well,
So.
thank you very much.
Thank you.